All right. This lecture is titled Cardiac Responses to Stress and Disease. You'll note when we look at our table of contents, we're really going to talk about primarily acute aerobic adaptations and some adaptations to exercise, and just a few cardiomyopathies. And I understand that a lot of this could be a review from things that maybe you talked about in 335. I really want to integrate that information with what we've talked about for the last few weeks. So, as you know, during exercise, whole body oxygen uptake, or VO2, increases in proportion to exercise intensity. And this is really a function of cardiac output and oxygen extraction, as we describe it via the Fick equation. So, VO2, and this cardiac output is what we're really going to focus on today, being at 603 in cardiovascular physiology. I'm not going to worry about the extraction side of things. That is for another lecture or another class. And if we look over here, we look at the relationship between work rate. So this is from a cycle ergometer in watts, and this is that VO2 oxygen uptake. And we can see that all of this line, that we get these plateaus that progressively sedentary, normally conditioned endurance athlete. So this is where we get your VO2 max. Now, this increase in VO2, we really want to understand how does cardiac output change to drive this, and the various factors that we've talked about over the last few weeks, how do they change to change that cardiac output? So briefly, during aerobic exercise in just moderately trained individuals, cardiac output generally increases at about 5 liters per minute, or from 5 liters per minute to about 25 liters per minute during maximal exercise. And the slope tends to be about 5 liters per minute for every 1 liter increase in oxygen uptake. And we can see over here in my figure to the right, here's our cardiac output, our oxygen uptake, and we can see this progressive increase. Here's our athlete, here's our normal adult, and this is actually mitral stenosis. So this would be like a cardiac patient. And we get this, as we've talked about in previous lectures, this increase in cardiac output is through a coordinated increase in both heart rate and stroke volume. Also important is that cardiac output is decreased in your older adults by about 80 to 90%. And this does vary based a little bit off of training, but we see it in both trained and untrained individuals. So here's cardiac output. The top panel is in sedentary and trained men, and the bottom panel is sedentary and trained women. VO2 is on our x-axis here for both of these, and cardiac output. So if we look in both sedentary men and women, those who are younger, that being the open circle, get this nice increase in cardiac output. With the older adults, following the same trajectory, but having about an 80% lower cardiac output. And we see that same trend, whether you're trained men or women. So significantly lower cardiac output with aging. This is important given the advanced age, growing age of the population. So now let's take a step and look at how does heart rate change with exercise, and how do we see that change with aging, and same with stroke volume. So as you may recall from previous classes, with any type of isotonic or isometric exercise, heart rate increases initially through both parasympathetic inhibition and subsequent sympathetic stimulation. So this parasympathetic withdrawal, sympathetic activation. And it's this reciprocal change in these two arms of the autonomic nervous system that permits heart rate to increase during exercise. And we can see in my figure here the parasympathetic withdrawal, sympathetic activation. This relationship is largely linear, and the slope is both dependent on the muscle mass involved, so we can change that slope and give an individual, but also is going to be dependent on training status. And while it's beyond the scope of this particular class at this point, the mechano and chemoreceptors, we'll talk about a little bit about this. But that's really more for Dr. Kopp's autonomic physiology course, or what's really driving this increase in heart rate. So we can see here our oxygen uptake and heart rate in our three individuals. The thing to really note is right around this 100 beats per minute, that's where we really get the transition from being parasympathetic to sympathetic, that above 100 beats per minute, we're almost entirely a sympathetic driven increase in heart rate. And we have 3 individuals here, all of a similar age. We can note the slopes considerably different because of their fitness level. Now, how do we get, how is it, and this is a little bit building off of previous lectures, so how does this sympathetic and parasympathetic driving some of these changes in heart rate? Well, if you remember, increases in sympathetic stimulation at that SA node up in the right atrium leads to an increase in heart rate via several mechanisms. A key one is an increase in calcium that results in more robust activation and depolarization, which shortens that phase 4 of the SA node. That increases the heart rates. This is really building on what we talked about in the first half of the semester here. We also know that cardiac output in an average non-trained individual is going to result in this, several-fold increase in cardiac output. And in the upright position, it's this exercise tachycardia, this increase in heart rate, is going to be responsible for about 60% of the increase in cardiac output. We can just another way of visualizing things we've talked about in previous lectures here. So if we can see, here's our beta adrenergic receptor. Here it is unstimulated. Here's a receptor. Let's add beta agonist. This could be things like norepinephrine. Once that binds, we have our series of events here that, importantly, increases the number of action potentials because it's having an impact on that phase 4 slope. It's steeper compared to up here. It's much more shallow. This is just driving the change in heart rate. That maximal heart rate really influences the age-related reductions in maximal cardiac output, such that we see that max heart rate decline with age at a similar rate, whether you're trained or sedentary. So if we look at heart rate as a function of VO2 over here in my right figure, again in sedentary and trained men and women, and younger and older, see that our younger adults get to a maximal heart rate compared to our older adults, regardless of training, do not achieve the same heart rate. So that lower heart rate. And again, because this increase in heart rate, this tachycardia, accounts for about 60% of the increase in cardiac output, this age-related reduction in heart rate is a key driver in why max cardiac output is down with aging. So why is it? Why does this heart rate go down with aging? Well, there's a couple theories, and I want to highlight them here because I think they're really important. Age-dependent slowing of this max heart rate seems to be due to slower firing of those SA node myocytes. So back to our basic physiology, those SA nodes generate that action potential. And there's 2 things that tend to happen. One, we see a reduction just in the intrinsic firing rate of those SA nodes. So if we compare young and old SA, this would be SA node fibers, and these are the action potentials we talked about early in the semester. We compare young to aged, that intrinsic, that automaticity is decreased with aging. There's also evidence for reduction in the beta adrenergic receptor stimulation, meaning that these receptors that are being stimulated by the sympathetic nervous system, looks like norepinephrine that would then result in increases in action potential and increase in heart rate. These aren't working as well in aging. They don't respond. When we actually look in humans, isoproterenol, which is a beta-adrenergic agonist, meaning it's going to stimulate beta receptors. We look at the change in heart rate here in our normal adults. We get this nice big increase in heart rate. In senescent adults, so our older adults, much lower response. So that means that those beta receptors are not responding as well to stimulation. So as sympathetic nerve activity increases, there isn't as big of an increase in heart rate as we age. And that's a major contributor to why you have a lower maximal heart rate with aging, and therefore contributes to the lower stroke or cardiac output that we see with aging. The other side of our equation for cardiac output is stroke volume. So how does it respond to exercise and aging? So as you recall from previous classes, we get an increase in stroke volume with exercise, and this increased stroke volume, so here's stroke volume as a function of exercise intensity, we get this nice increase. So we get this progressive increase in stroke volume, plateaus with incremental exercise around 40% of peak. And it's achieved by increases in end-diastolic volume, decreases in end-systolic volume. So the stroke volume is the difference between these two. If you remember back to our Wiggers diagram on our pressure volumes. So what is it that allows this end-diastolic volume to get larger? I know you've mentioned this it's been mentioned in other classes. I want to take a little step further. But this increase in end-diastolic volume largely occurs with incremental exercise because increases in venous return, because of the skeletal muscle pump. There's also the abdominal thoracic pump and some vasoconstriction. And what happens, to relate this back to the basic principles that we've discussed over the last few weeks, all goes back to the starting law of the heart, that contractile force increases proportional to muscle fiber length. This is what would occur with the increases in end-diastolic volume. So we can actually see this increase in venous return in a couple different ways. So here's VO2, and this is pressure. This is capillary wedge pressure in the lungs. So not the alveoli, but the pulmonary capillary basically is a measure of left ventricular preload, and this is the right side of the heart. So these are both measures of ways in which we can measure preload. See that they both go up as VO2 increases. Over here, it's another way of looking at it. So this is time in seconds. Here's our exercise onset, and this is pressure. So BA, this is brachial artery pressure. This RA is right atrial. Again, this is an index of preload. Note at the onset of exercise, immediately increases. So we get this increase in preload with exercise, which means, take it back to the basic concepts, that if we move from here to here, we've resulted in some increased resting tension, some stretching, that moves us up the Frank-Starling curve, and we get more force. This would result in an increase in stroke volume. We also see that there's better relaxation. This promotes filling during diastole, which is going to give us a better end-diastolic volume. And this is due to reuptake of calcium into the sarcoplasmic reticulum. This is, again, remember we mentioned that the sympathetic nerve activity, these are beta-adrenergic, things like norepi, our sympathetic nerve activation, bind to that beta-adrenergic. That phospholambin allows for this circuit channel to take up that calcium. That means improved relaxation and better filling during exercise. What about the other side? We've got our in-systolic volume. We want that to get smaller, lower during exercise. We're ejecting more blood as we exercise. So that progressive decrease in systolic volume is achieved by increasing myocardial contractile function or contractility. Now remember that our active tension, how much tension we can develop, which force, is related to the amount of calcium. So if we can get more calcium into the cell at the appropriate time, we get better contraction. That's a unique feature, remember, of cardiomyocytes. So what are the factors that would influence the amount of calcium being released by the sarcoplasmic reticulum during excitation contraction coupling? Well, the first is heart rate. This was referred to as a staircase phenomenon, that as we exercise, we get this increase in heart rate. And we can see over my figure to the right, this is a representation of the heart rate dependent increase in contractile force development. So as we start here with, there's 1 heartbeat, 2 heartbeat, 3, 4. There's 4 beats in this 4-second time frame here. And here's the contractile force. If we increase heart rate, this dotted line here, as this heart rate increases, muscle contractile force increases to a new steady state. And this is all to a transient imbalance in cellular calcium influx. So we get this progressive increase in calcium from the sarcoplasmic reticulum on a beat-by-beat basis, just by heart rate going up. We also know that with sympathetic nerve activity can increase contractility. This is what's helping us during exercise. So that sympathetic nerve activity increases the amount of calcium being released from those L-type calcium channels we've mentioned before. And we can actually see in my figures to the right here. So here's contractile force and time. Here's sarcoplasmic reticulum calcium under different conditions. This is with sympathetic nerve activity. More calcium being released from the SR, more contractile force. We also get better uptake of calcium back into the sarcoplasmic reticulum. We mentioned this previously with the phospholambin, but if we pull more back in, that means it's got more to be released next time, so we get a better calcium gradient. With advancing age, what happens to this stroke volume and why does it change? What we see as you age, that maximal stroke volume can be reduced by up to 80 to 90%. And the figure on the right really gets into this a little bit. Again, sedentary and trained young men and women and older men and women. We can see the reduced stroke volume. So here's younger adults, trained and untrained, are older, considerably lower. This age-related decrease in stroke volume is accounted for in a reduction in the maximal ejection fraction without an increase in end-diastolic volume. Basically means the heart doesn't fill as well and it's not contracting as well. And if we look at the effects of aging, so here's age, and this is the ejection fraction. And here's stroke volume index, just meaning it's stroke volume normalized to their body mass or body surface area in this case. We can see stroke volume goes down as we age, and so does ejection fraction. So if we dig into some of the animal studies, it all kind of suggests this may be due to impaired calcium handling as we get older. We can't fill the heart as well as we age, which means aging is associated with diastolic function decreases. Older adults have a lower end diastolic volume for any given preload. This is due to the ventricle being stiffer. Remember in the previous lecture I mentioned that we can use echocardiography and that E wave to measure rapid filling during diastole. Well, if we look at LV relaxation here, during that E prime phase, we see that it decreases with aging. And this is an idea, one way in which we can identify a stiffer ventricle, that we can compare sedentary athletes and young individuals. So we can see our young and our athletes are over here on the right, that this is volume related to pressure, which is a nice measure of compliance. We see this shift in the older adults, that they just have this stiffer left ventricle. So it doesn't fill as well at rest or during exercise. What about adaptations to exercise? What takes place? And there's a variety of things. Well, I've mentioned and we've seen just previously in some of the figures of trained and untrained men and women that these changes in cardiac dimensions and blood volume really are a big driver of the stroke volume and cardiac output changes highlighted above that come with training. And we can see here, this is training times in month, wall thickness, and in diastolic volume. We can see these changes. And this is just a visualization, but it does take several months in a lot of cases for true end diastolic volume to change. So with this endurance type training, we get left ventricular hypertrophy, larger diameters, and some wall thickness. So what actually is happening at the cellular level to allow these chamber dimensions and hypertrophy to occur? And what happens with training is these increases in LV mass and volume are due to longitudinal, this is important, longitudinal cardiomyocyte growth. We're adding sarcomeres in series, and this is referred to as eccentric ventricular hypertrophy. And if we look at my pathway here in the center, here's normal. This takes us down what's referred to as physiological hypertrophy. These cardiomyocytes get longer. Compare that to pathological. Note they get very thick or they get very thin and long. It's two types of cardiomyopathies. We can see this if we actually look at the individual cells themselves as a function of VO2 max. And this is an animal study, so that's why the VO2 maxes are really, really high. The cell length, function of training duration, cells get longer, and the mass of those cells also goes up. Again, key characteristic of physiological hypertrophy in response to endurance training. Because this lecture is stress and disease, I want to just briefly highlight some of the cardiomyopathies. And these would be the types of adaptations that we're talking about on this pathological side of things. So cardiomyopathies in general are it's a very diverse term for a variety of diseases that affect the myocardium. And it's all associated with remodeling. Now, we're not going to get into the pathophysiological mechanisms. That's not really appropriate for this heart. But a lot of times, this is in response to ischemic heart disease, like coronary artery disease, or long-standing hypertension. We tend to define these or categorize them as dilated, hypertrophic, restrictive, based off their tissue characteristics. And you can get a brief idea if we look at the image over here to the right. Here's normal, dilated, thin walls, big chamber, hypertrophic, very thick walls with a small chamber, and restrictive looks normal, but the characteristics inside the cells here, or inside of the wall, are dramatic. You see this was like amyloidosis. So let's just talk about a couple of these and relate them back to some of the concepts we talked about for the last few weeks. First is dilated cardiomyopathy. This is characterized by an enlarged left ventricle with reduced systolic function and is measured by left ventricular ejection fraction. So it's very big heart that doesn't pump very well. So again, characterized by impaired systolic function. And this leads to an increase in intracardiac volume. So if we look at this is our pressure volume loop. Here's our volume, here's our pressure. This is the black here, switch my marker here, this is normal. This is our dilated. Note, very big stroke volumes. But if we actually do the math, not really ejecting very much of it. So we've got poor ejection fraction. We can see visually over here, thin walls and really dilated. So it's carrying a lot of volume and can't get rid of it with each beat. So it's going to give us a decreased stroke volume and therefore decrease in cardiac output. Hypertrophic cardiomyopathy can break down into two different types. Both are very thick walls. One is in response to things like hypertension or valve disorders, which I'll talk about, and one is hypertrophic obstructive cardiomyopathy, or HOCM. So this first one, in response to hypertension, really can be explained by the law of Laplace. If you've got chronically elevated afterload, remember that's the work that the heart has to go against. So classic example of this is hypertension, high blood pressure, as we mentioned. We have sustained elevated blood pressure. It means the heart has to generate these big increases in LV pressure. That puts a lot of stress on the wall. And if we put more stress, it needs more oxygen. So the heart is going to remodel in response to this. So if this T is tension, this P is the pressure inside the heart, and the H is the wall thickness. The law of Laplace is defined here as this equation, that if this tension goes up because there's an increase in pressure, and it's this tension, this wall stress here, that determines what's related to VO2 of the myocardium. This wall tension goes up because there's increased pressure here. This increase in pressure is due to hypertension. The way to normalize this is increase the thickness, which is my variable H here. So if the heart increases its thickness when there's this increased pressure, that cancels this out and brings our tension back down to normal. The other type of hypertrophic cardiomyopathy is hypertrophic obstructive cardiomyopathy. This is really important, and there's a major push to identify this. This is a major risk factor for sudden cardiac death in young athletes. So this is defined as a left ventricular hypertrophy in the absence of abnormal loading conditions, meaning they've got very, very thick walls. And you can see here, here's the septum. Look how thick this septal wall is. Here's the lateral wall, very, very thick. This is developing when there's no hypertension, there's no valvish orders. And if we actually go in and look at the cardiomyocytes, it's almost like a thing of spaghetti here. Misalignment and disarray of those myofibrils and myocytes. Poor connections, not a nice path. This is an inherited disorder because there's a familial and major subtype, but it's not always that case. It's characterized from a pump function standpoint with diastolic dysfunction. This is due to impaired relaxation, stiffness of that chamber. And during exercise, a large number of these individuals can't develop a normal blood pressure response. And this is due to what's referred to as a dynamic left ventricular outflow tract obstruction. So we go back and we use that echocardiography I mentioned in previous lectures. So here's the septal wall. This is the aorta. This is the left atrium. This is the left ventricle. So ideally, the blood goes out like that. Well, what happens is when the heart contracts in these individuals, note that here's the mitral valve, here's the left ventricle, here's the aorta. Note that it pinches. It's much harder to get that blood to eject out. This area here, this is that left ventricular outflow tract. And this is where Wiggers comes into play. This is the pressure in the aorta. This is your aortic blood pressure. Here's the left ventricular blood pressure. Note that the LV has to generate crazy amounts of pressure to get past this obstruction. So we get this obstruction occurring in about 1/3 of patients at rest and 1/3 during exercise. And this has a profound impact on left ventricular volume. So we put that into whole context of why we care about this. Because this is not something that develops over age, this is something you're born with, essentially. We see this as a major problem in young athletes. So we get this thickening and disarray of left ventricular myocardium. Now, hopefully you're thinking already that, well, if there's disarray of those myocytes, the conduction of those electrical signals are going to be interrupted or altered, meaning now my young athlete who has this hypertrophic cardiomyopathy is potentially at risk for ventricular arrhythmias and sudden cardiac death. If that wall gets really thick, so that septum gets thick, that can narrow that outflow tract that I was talking about up here, which means we can't generate, that flow doesn't happen. So we get this impaired ejection that can impair stroke volume because it's a stiff ventricle. We can get impaired stroke volume, and that can drive decreases in cardiac output and fatigue. The last things I'll talk about today, still in our realm of cardiomyopathies, is heart failure. And I'll relate these back to some of our key physiological functions. So heart failure is any condition in which the heart cannot generate adequate cardiac output, resulting in inadequate tissue perfusion. And it's the final pathway for a variety of cardiovascular diseases, hypertension, coronary artery, valvular disease. And because some patients don't show the signs of overload, that's where the older term of congestive heart failure is not always used. When I'm referring to chronic heart failure, this means they've had long-standing, and they're really largely stable. Acute heart failure means that it's rapid onset, so they just developed heart failure very, very quickly, or it's any worsening of heart failure symptoms, so they're acutely decompensated. And the challenge with heart failure is we often work on a spectrum here. So disease progression is on the x-axis here. So you can have acutely decompensated and de novo. What I really want to highlight in this particular figure are these two types down here. Don't worry about the up here. Is that we've got two subtypes of heart failure, of a LV systolic and diastolic function. So let's begin with the reduced ejection fraction, or the systolic. So heart failure with reduced ejection fraction, or HFrEF. It used to be called more often systolic heart failure. And it's really defined as heart failure where there's a poor ejection fraction. So poor contractility, it can't generate the cardiac output because it can't eject the blood. Again, impaired contractility, and this has to do to a variety of things, including changes in calcium ion channels and transport mechanisms associated with the sarcoplasmic reticulum. All of these things have been associated. Because if you, again, go back to the relationship between calcium and relative tension, that is a major driver of what's happening. And I love this figure because it highlights a few things. So let's start with this is infarct, so they had a heart attack and developed heart failure, and they're sedentary. Here's calcium, and here's cell length, so ability to shorten. And if we just draw a dotted line straight up here, note that the sedentary heart failure rat, for a given calcium, doesn't shorten very much. Compare that to our sedentary sham, trained, meaning they haven't had heart problems, they're down here. And notice that if we train that individual that had a heart attack, we start to get a response back. So this is part of the evidence for why we would have someone go through cardiac rehab. So with HFrEF and poor contractility. If we relate that to our pressure volume loop, with systolic heart failure, that insystolic pressure volume loop is shifted downward, such that with the systolic emptying, we don't get as good as of empty. So we get this shift like so. So can't eject as much, and our stroke volume falls. Notice that this being our stroke volume is dramatically lower. This extra blood, because it can't eject, means that everything is also shifted way to the right. This is what can drive pulmonary venous changes in venous return. We talked about the congestion a little bit last time, and how if you reduce stroke volume or reduce cardiac output, you can get high venous pressures. The clinical manifestations I'm not going to highlight. This is just kind of for your own information if you're interested. We get forward and backward effects. The forward effects, those as you would expect, are, I am going to highlight one thing, associated with hypoperfusion, things like weakness. So that's why we've got poor, one of the reasons there's poor exercise capacity in those with left ventricular heart failure. The other type of heart failure I want to note is diastolic heart failure, meaning there's really no real apparent systolic dysfunction. They've got a normal ejection fraction. So that's where the term heart failure with preserved ejection fraction comes to play. And this means that the heart just cannot relax as well. It's very, very difficult to fill. So the pressure volume loop is altered so that the ventricle fills at much higher pressures than normal. Remember, we talked about the end diastolic volume pressure relationship. This is normal. With HFpEF, it gets shifted up. It's very, very stiff. So as the volume goes up, the pressure inside of it also goes up. It's very stiff. This is all because there's an impaired compliance. Same thing, though, is above. With systolic heart failure, there's a low stroke volume here. There is a smaller stroke volume compared to normal. So this lecture just highlights a little bit of building on the things we've talked about for the last few weeks. Cardiac pump, how it's changed in response to acute exercise, aging, and a little bit of disease.